Hi, I'm Steve Selling, founder of FitTest, and this is the continuation of my small series on chronic heart failure and exercise, directed for exercise professionals. And in part two, this video, I'm going to talk more about heart failure with preserved ejection fraction, or sometimes known as diastolic heart failure, and present a case study in relation to this topic. So just continuing on with some of the slides that I had in part one, it's worth repeating those slides. So what is heart failure? So if we look at heart failure in a healthy heart, it's got good blood supply, it's got good oxygenation, and it contracts with normal size and normal function to produce normal cardiac output. When someone goes into heart failure, the unifying clinical feature is a reduction in cardiac output, and often the heart has to work harder to produce that same cardiac output that is needed for life. So the hallmark sign of heart failure is low cardiac output at rest and also in exercise, both submaximal and maximal intensity exercise. That's the hallmark sign. The hallmark symptoms are breathlessness on exertion, or shortness of breath on exertion, and also shortness of breath at rest sometimes. Fatigue during exercise and even at rest. There are functional classifications, and the main ones are based on the New York Heart Association scheme. New York Heart Association Class 1 are symptoms at high intensity exercise. Class 2, symptoms at moderate intensity exercise. Class 3, symptoms at low intensity exercise. And Class 4 have symptoms at rest. And these are the ones that are the most difficult for us as exercise professionals to work with, the most challenging. And as I said in part one video, Class 4, chair-based exercise using smaller muscle groups or even small muscle groups are probably the way to go. And I also emphasised in part one that interval training, sometimes high intensity interval training, but mostly low and moderate intensity interval training works really well for Class 2 and Class 3, and to a lesser extent Class 4 heart failure. Class 1 heart failure are essentially normal, and you can treat them as normal unless they have other significant comorbidity. And now coming to the topic for today, heart failure with reduced ejection fraction, which is part 3 video. And the subject of this video is heart failure with preserved ejection fraction, or HFpEF, or otherwise known as diastolic heart failure. Although these terms are not mutually exclusive, often there is both systolic heart failure and diastolic heart failure features found in each client. So just continuing on with what is heart failure, here we can see a left ventricle, and I've just outlined that, showing the internal dimensions of the left ventricle, normal wall thickness, normal pressures developed inside the left ventricle on contraction, and normal output, as in cardiac output, into the aortic arch. Now, if we have a heart that is enlarged with maybe some wall thinning and some wall weakening, this is known as heart failure with reduced ejection fraction, or systolic heart failure. Typical presentation is large dilated ventricle, but it doesn't only have to be that. It could be survivors of myocardial infarction who have essentially normal dimensions of the heart before that heart remodels, but very poorly contracting regions of the heart. And if they're large enough, that will result in an overall reduction in contraction, overall reduction in stroke volume, and that then transfers into a reduction in cardiac output, which is the hallmark sign of heart failure. So we can have a large dilated ventricle, but we don't always have to have that to have heart failure with reduced ejection fraction. The primary example of someone with normal looking, I guess, ventricle is someone who's had a large myocardial infarction, but before the heart is actually remodeled to be a large dilated ventricle. Now, heart failure with preserved ejection fraction or diastolic heart failure is quite different. Small chamber size, small, thick, stiff ventricle. The problem is filling, not so much the pumping, although the pumping is impaired as well. And that's where we got this crossover. We have lots of crossover between diastolic heart failure and systolic heart failure. And it's not one or the other. Often there's both. And in the small, thick, stiff ventricle, the problem is filling reduced, and the filling pressures go up and the filling volumes go down. And so we have, if you've got less filling, then you're going to have less stroke volume as a result of that. And again, the hallmark sign of heart failure, reduction in cardiac output, but coming from a different mechanism. Just before I leave this slide, in relation to the large dilated ventricle, I strongly recommend that you watch my other YouTube video on preload, or the Frank Starling law of the heart, where I show or go into a lot of detail about this form of heart failure here. So now, just before I get back to heart failure, just a slight diversion. And this is old data, but published in Circulation in 2011. And this is really decades of data here, of which this data set is part of it. A very large number of men, 14,000 plus men, showing both all-cause mortality and cardiovascular mortality in the blue. And if we just take, and what happened was there were two exercise tests, two cardiorespiratory exercise tests for cardiopulmonary fitness, 6 years apart. And so if we take the control group as those who were unfit at the first test and remained unfit, then what happens is we can then compare to those who started off fit and remained fit throughout. They have about half the death rate over that 6 year period. And those who started off unfit but became fit, they almost normalised to those who had remained fit all the way through. This is extremely encouraging. And they go in the exact opposite way of those who started off fit but then became unfit, with a very large increase in their mortality outcomes. So this is very good and strong longitudinal data showing the benefits of improving and then maintaining fitness over a 6 year follow-up period. And obviously my app Fit Test is totally suitable for not only estimating VO2 peak in the first place, but also tracking VO2 peak, estimated VO2 peak over time. So now we come back to HFpEF, or heart failure with preserved ejection fraction, and the situation for exercise. And this is a lovely paper published by Hayekowski in Journal of American College of Cardiology in 2012. Strongly recommend you have a look at this paper. What Mark Hayekowski and colleagues reported on, well, first of all, just using the FIC formula, cardiac output times O2 AV difference, where cardiac output times O2 arterial minus cardiac output times O2 mixed venous, and the arterial oxygen concentration, which is one of the all-important parameters in this formula, is heavily dependent on hemoglobin concentration and O2 saturation. So correct anemias if hemoglobin is low, or any other source of hemoglobin being low, and correct O2 sats being low if they are low, by dealing with lung function, which is one of the things that come up in this case study in this video, but also other causes of O2 sats being low, such as congestive heart failure, where you have pulmonary edema, which I'm not going to talk about here, but I've talked about in other videos. Central effects. Now, coming to Mark Hayekowski's paper, the central effects that they showed was really just limited to an increase in heart rate peak. Now, this may be related simply to an improved exercise tolerance after the training. so that the person could get more out of themselves, and that manifested as an increase in heart rate peak. But there was no change in stroke volume, and there was no significant change in cardiac output because of the heavy influence of stroke volume on cardiac output. There was also no significant changes in end diastolic volume or preload. So centrally, the main or the only change was an increase in heart rate peak. Peripherally, there was an increase in oxygen utilisation peripherally, and this was the main contributor to the improvement in VO2 peak, which I'll show you on the next slide. And this was attributed to an improvement in microvascular and or skeletal muscle aerobic function. Now, to come to Mark's data, the exercise group showed an improvement in VO2 peak of an increase in 2.3 mils per kilogram per minute. So that's a very clinically significant and a very useful increase in VO2 peak that each client with these fairly low VO2 peaks would feel, and this would translate to better function, better fitness, and probably better quality of life. Now, just to present the graphical data in relation to the previous slide, the heart rate peak, so this is the training group and this is the sedentary group. The training group managed to increase their heart rate peak in the follow-up testing, and they also increased their oxygen utilisation at the periphery, shown here. But they did not increase stroke volume. In fact, there was a small tendency to decrease, and cardiac output overall didn't change for either group. So this is really the encouragement here, is that you can get HFpEF clients fitter, and that's something that we really need to bear in mind here. So to come to the summary of HFpEF and exercise in the literature that I've reviewed for this presentation, first of all, exercise intolerance, that is early fatigue and early breathlessness, especially on exertion, are the primary symptoms among patients with HFpEF. Exercise training in patients with HFpEF, we can get increases in cardiorespiratory fitness and improvement in symptoms, including improvements in quality of life, but without improvement in central left ventricular systolic function or endothelial function or arterial stiffness centrally. Exercise training in HFpEF patients does not equate to an improvement in cardiac output or central improvements. However, if we have a decrease in VO2 peak due to disease, that translates to an increase in mortality in cardiac patients in general and heart failure particularly. And VO2 peak is better for predicting cardiorespiratory fitness or predicting improvements in cardiorespiratory fitness than the 6-minute walk test in elderly clients with HFpEF. And this is an important finding, and obviously FitTest does this very, very well in the estimates of VO2 peak, and I suggest you go and have a look at the app. So now we come to my client who has hypertrophic cardiomyopathy and asthma, 35-year-old female. So her presentation was she's had a long-standing asthma and eczema. 2004 was first diagnosed with hypertrophic cardiomyopathy. In 2016, she had what she described was a frightening episode of exercise-induced tachycardia during soccer training that required an ambulance to be called to the soccer ground, and she was hospitalised for that episode. In 2019, her hypertrophic cardiomyopathy had progressed to the extent where, although she has normal systolic function, she has moderate diastolic dysfunction with an increase in preload, left ventricular end diastolic pressures. And again, I would recommend that you go and watch my YouTube video in this series on the Frank Starling law of the heart, or preload. Medications, Symbicort, which is a polydrug consisting of the corticosteroid and the formoterol, which is the LABA. This is the anti-inflammatory preventer and the LABA is the long-acting beta-2 agonist or symptom controller, and this is otherwise known as a long-acting bronchodilator. So this is for long-term symptom control, and this is the preventer. So she's taking that no problem in her maintaining that prescription and continuing to take that drug as prescribed. And she also had Advantin for eczema. Now I'm sorry about this busy slide, but I won't cover all of it in depth. But what I basically did with this client is I wanted to fully examine her lung function to make sure that we weren't getting problems with that could potentially add to her HFpEF, her heart failure with preserved ejection fraction or hypertrophic cardiomyopathy. I wanted to make sure that her lungs were at least operating optimally. So we did a pre-exercise, pre-SABA. Now, SABA is short-acting bronchodilator or short-acting beta-2 agonist, and Ventolin was used in this case. But this was pre-exercise and pre-Ventolin. So the size of her lungs were 81% of predicted. Her peak flow was 102% of predicted. Her medium-sized airways, so peak flow are large airways, medium-sized airways were about 76%, and small airways about 65%. Now, the 65% might seem low, but really that's very, very common, and you wouldn't treat on that alone. That's a high enough figure not to treat further. And when we went to pre-exercise post-Ventolin, so she had Ventolin, then 10 minutes later had a repeat test, there was really no change at all. And then post-exercise, there was a small improvement in the volume, but no other changes of any significance to the airways. And then we also did exercise spirometry, and we were able to estimate her maximal voluntary ventilation to be 91 litres. Her ventilation at peak exercise was 41 litres, which means she had an extremely satisfactory or very good breathing reserve. And you can see here her actual spiral or her flow volume loops, sorry. So peak flow here, pre and post SABA, a little bit of asthma pattern there, but nothing particularly dramatic, and certainly wouldn't need any change to treatment. Completing the loop here very nicely. And so there was really nothing to say. And my conclusion was her lung function is not going to get in the way of her hypertrophic cardiomyopathy, so we could then move on, which is a good finding. So when we moved on, one of the things that surprised me, because I hadn't seen it before, was a little bit of ST depression at rest, but that was not really of great note. I noted it, but it's not particularly significant. But when we went to exercise, we got this ST depression and T-wave inversion that was in the lateral leads and very noticeable in V5, V6. You can see where I'm pointing here with these black bars showing ST depression. Now, when I went to read up on this further, I found that for hypertrophic cardiomyopathy, this finding is very common. I haven't got the literature here, but that doesn't indicate coronary artery disease or ischemic heart disease per se. It's really just a common finding with this condition of hypertrophic cardiomyopathy. So I noted it, but it wouldn't have resulted in any change to treatment. Her heart rate response to exercise is shown with a green graph. And this is the incremental exercise test that I conducted. This is active recovery to here and then passive recovery through here. And she had a completely normal response to exercise in terms of heart rates. And don't forget, she's not taking beta blockers or anything at this stage. So relatively young woman, but we certainly could not find the tachycardia that she had during exercise. Now, what we are going to do with this client, because she's had a scary event, we're on the soccer field. She's actually a soccer goalkeeper, and we're going to simulate a soccer goalkeeping training session with lots of jumps and moves sideways and moves forwards, all sprint and strength and power activities. So we're going to simulate that with ECG and with heart rate monitoring when we see her at her next appointment. Now, just to continue on with some of the literature about HFpEF, or actually, yes, HFpEF, and of which our client, Emma, has that condition with hypertrophic cardiomyopathy. I'm not going to take you through these complicated echo measures of this. You can certainly find this on the web, and the reference is there. Zeil and Brute set in Circulation 2002. You can find the primary reference very easily, and Circulation is free to the public on the web. Exercise training increases maximal exercise capacity, which is a good thing. Increases left ventricular diastolic function indices. Now, it's beyond the scope of this video to go over the actual indices, because that would take me 10 minutes, 15 minutes just on their own. You can get very good videos online about these topics. And if you want to follow this up, I would follow up E prime. Very, very good YouTube videos to explain these indices very well. So I'll just leave it that in these studies, Edelman and Dieberg, published in exceptional journals, they found that there was improvement in diastolic function and quality of life in patients with HFpEF who were training. However, other studies looking at diastolic function using parameters such as left ventricular end diastolic volume, or E to A ratio, that is the passive ventricular filling to active ventricular filling through the left atrium, for patients with HFpEF did not support the findings above. That was mainly in a meta-analysis by Pandy published in Circ Heart Failure in 2015. And again, an excellent paper that I would recommend to you if you want to read further on this topic. So I think the jury is still out on whether exercise training in HFpEF clients is going to improve their central indices and particularly their diastolic function. The jury is out, and we just wait further research for confirmation one way or another, or maybe it can't be confirmed. So thank you for watching this short video on HFpEF and my case study of Emma, 35-year-old female. And please get back to me on info@myfittest.com.au with any questions or queries, or if you'd like any topics covered.